Hello friends, so this is lecture number 3 of the chapter Epidemiology of Communicable Diseases, and today we are going to learn about National TB Elimination Program. We will learn about its goals, objective along with its component in detail. I have already uploaded videos on topics like ASHA, ICDS and PHC and many other topics. You can check them out, the link is given in the description section below. So let's get started. NTEP provide goals and strategies for countries' response to disease during the period 2017 to 2025 to bring about significant changes in the incidence, prevalence and mortality of TB. The vision is TB-free India with zero death, disease and poverty due to TB. The goal is to achieve a rapid decline in the burden of TB morbidity and mortality while working towards elimination of TB in India by 2025. To achieve this goal, the program focuses on several clear objectives. The first objective is to find every person affected by TB, including both drug-sensitive and drug-resistant cases. Special attention is given to people who seek care from private healthcare providers as well as those belonging to high-risk population and are undiagnosed. The second objective is to ensure that every patient diagnosed with TB receives the right treatment and continues it until completion. Whether a patient seeks care in the public or private sector, the program aims to make the system as patient-friendly as possible, providing social psychological support so that no one drops out of the treatment. The third objective focuses on preventing the emergence of disease in susceptible, that is, reducing the number of new TB infection, particularly among population that are more vulnerable or susceptible. The fourth and final objective is to build and strengthen the overall system. This includes creating enabling policies, empowering institutions, recruiting additional human resources with enhanced capacities, and ensuring adequate financial resources to sustain the fight against TB. The program is structured around 4 key components, that is detect, treat, prevent and build. We will learn about each component in detail. Let us see the first component, that is case detection. The program uses two main mechanisms, that is passive case finding and active case finding. In active case finding, there is systematic active TB case finding in high-risk groups. The program has proactively conducted house-to-house searches of TB cases among the high-risk population like people living with HIV, healthcare workers, prisoners, slum dwellers, minors, difficult inaccessible areas, also the malnourished people, diabetics, patient on immunosuppressant. The screening is based primarily on symptoms. The screening takes place both in the institutional settings like hospitals and in community settings where the healthcare worker conduct door-to-door visits or hold a screening camp at fixed site or through mobile units. So this active screening is conducted 3 times a year in a campaign mode to ensure wide coverage. So presumptive TB is diagnosed using standard case definitions and diagnostic algorithms are used to diagnose pulmonary TB, extrapulmonary and pediatric TB. When someone shows symptoms suggestive of TB, further diagnostic tests are conducted following the standard diagnostic algorithms. The investigation may include sputum examination using methods such as smear microscopy, fluorescent microscopy, line probe assay, CB-NAT or even solid and liquid cultures. Chest X-ray and other investigations such as tuberculin test and FNSC may also be used. The diagnostic facilities are available both in the public and the private sector. In the public sector, diagnostic centers collect and transport the sputum sample and purchase services from private labs. In private sector, there are empanel accredited labs. The cost of investigations are subsidized. In medical college, there is culture and drug sensitivity testing carried out. The second component is treatment. Treatment under the program is available for all forms of TB, including drug-sensitive, multi-drug resistant, and extensively drug-resistant TB. In government hospital, patients receive free consultation and free medicines. In private hospitals, the government provide free drugs, and to encourage treatment completion, incentives are given. The patient also receive free consultation or reimbursement of fees. Medical colleges have designated drug-resistant TB center and ward. For drug-sensitive TB, The treatment follows daily fixed dose combination regimens which are adjusted according to the new weight bands. Treatment algorithms are available. There is also bedaquiline excess program rollout. There is shorter MDR TB regimen. All treatment is guided by standardized national TB care guidelines to ensure uniformity. The treatment for isoniazid monoresistance and polyresistance are also available. Then, recognizing that TB completion treatment can be challenging, the program includes a comprehensive patient support system. This involves regular counseling for both the patient and their family, supervision by trained health workers, follow-up to retrieve any patient who interrupt the treatment. Patients are also monitored for adverse drug reaction, provided with psychological support, and are connected to nutritional supplementation scheme and social welfare programs. Digital tools such as SMS reminders, IVRS, electronic pill boxes, and 99 dots are used to promote adherence. Efforts are also made to reduce the catastrophic expenditure related to TB. Diagnosis and treatment are completely free in government facilities, while in private facilities the costs are subsidized or reimbursed. Support is also available for travel expense as per government scheme, nutritional needs through food security schemes, PDS linkage with NGO and direct benefit transfer, and loss of wages through linkages with skill development program and government schemes. The third component is prevention of TB. It has three measures. First is airborne infection control, second is contact tracing, and third is treatment for latent TB infection. So the first measure, it focuses on airborne infection control. This includes regular screening of healthcare staff, maintaining clean and well ventilated facilities, wet mopping with disinfectant, proper sputum disposal, and ensuring that the staff uses personal protective equipment. The patients are educated about cough etiquette, and in OPD, patients with cough are asked to wear mask. Other measures are screening and triage and fast track. In wards, there are separate wards for drug sensitive and drug resistant TB patients. HIV patients are not admitted in the same ward as TB patient to avoid cross infection. The second prevention strategy is contact tracing, in which we need to identify and screen the people who have been in close contact with a TB patient. This includes symptomatic contact, children under 6 years of age, immunocompromised individuals such as people with diabetes or HIV infection. Screening is done primarily through chest X-ray with forward tracing for adult patient and reverse tracing method for pediatric cases to identify the possible source. The third preventive measures involve treatment for latent TB infection. The treatment for latent TB infection is given to HIV infected children with tuberculin sensitivity test of more than 5 mm and exposed to infectious TB patient. All people living with HIV more than 1 year of age, children with positive TST test with TST more than 5 mm and who are on immunosuppressant, children who are born to women who had TB during pregnancy, children less than 6 years of age in contact with infectious TB patient, patient with silicosis, patient on immunosuppressants. So drug isoniazid 10 mg per kg per day is given for 6 months. We need to rule out TB before giving preventive therapy. The fourth component is built. This involves improving urban TB control system, strengthening the health facility, and carrying out advocacy, communication, and social mobilization or TB campaign to increase public awareness. In addition, the program supports research and innovation in TB diagnostic, treatment, and prevention, and provide technical assistance to strengthen implementation capacity. So for the effective surveillance, monitoring and evaluation, we need to establish TB surveillance system at district, state and national level to monitor the epidemiological characteristics of TB in the population over time and geography. We need to monitor the performance of TB control activities and feed this information into a decision-making cycle to allow for appropriate interventions to upgrade the district, state and national TB plans. Also, identify and describe the vulnerable population at increased risk for TB and unfavorable prognosis to which targeted public health activities will be addressed. So with this, we have come to an end of this lecture. If you found this video helpful, Like it, share it, and subscribe for more.